So I'll be talking on optimizing technology with the MAKO. Right, so I work at Sunshine Bone and Joint Institute at Hyderabad. It's a high volume center. Dr. Gurva Reddy is our mentor, and it was about 5 to 7 years ago that he was being approached to take this robotic systems, but there was no conviction. And the transition happened after viewing multiple centers all across the world. And once that decision was taken that, okay, this is going to add benefit to the patient, and yes, we will go ahead and acquire the robot, there were still many burning questions. And the two important questions is, it's a high volume center, so will it slow down the process flow? Will it slow us down? And since it is such a high cost, will we even break even? So this was back in 2020. Now, the factors slowing the process are pre-op and intra-op. Pre-op, the CT scan and segmentation process, the surgical planning, and then intra-op, the added steps of pins, registration, balancing, cuts, and then one single robot doing so many surgeries. So the first thing is that CT scan is mandatory for the MAKO. As you know, it's image-based. So the initial days in 2020, US and Hong Kong were just the two centers where we had to send each of the CT scans. So we would send it on one day, and then it would take 3 days to come back. So this turnaround time of 72 hours was too slow. So the patients who would come willing to get admitted with their suitcases already into the hospital, they would have to be told that this is going to take a lot of time. So by pushing the team, Striker, there is a local segmentation team that had to be introduced, and then the turnaround time became 12 hours. So even if the patient comes to the OP today, the next day the patient can be operated. And then the surgical planning, again in the initial days, it took a lot of time, about 20 minutes. Why? Because the three main steps were the CT landmarks. You have to go into the CT, look at the center of the femur, the center of the knee, tibia, ankle center, and then the resection landmarks. You have to make sure that the person has correctly put them out. So those were the things that were taking time. And then looking at the implant sizes in all three planes to see if the anterior notching is not happening, posterior offset is restored, the sizing, all of that. So that would take time. But as we develop more and more cases, we realize that all this can be done intra-op, and the person who does, in MAKO, it's called a MAKO product specialist, an MPS. If he's well trained, then we don't even need to check the CT landmarks and the resection landmarks. So the whole thing can be, this whole entire process can be eliminated. And then the intra-op, if you see the added time with robotics happens with the pins, registration, ligament balancing, cuts with the robotic arm. But if you see that really the time that it takes to do all this is hardly 2, 3, 5, so that becomes about 10 to 12 added minutes. But then what you save with the robot is, in the conventionals, the positioning of the cutting blocks and the jigs, the accuracy ensuring and the alignment, all this is the time saved. So essentially that incision to implantation will still be 45 plus minus 10. So that way it is time saved. And then again, single robot doing so many surgeries, around 10 to 15 surgeries is what the center does. So will one robot be able to do so many? So that process flow also, in terms of optimizing, was done like this. In OT1, if exposure, cuts and trialing is happening, that takes about 30 minutes. And that's the time when the robot is in that OT. And after that, during final implantation, closure and cleaning part, the robot need not be there. It can be shifted into the second OT. So the second OT is then immediately patient is in. And in the third OT, that the third patient is already into that stage. So if you see within a space of about 90 minutes to 120 minutes, you're able to do 3 single knees or hips, which is a total of 12 surgeries in a duration of 8 hours. So that way, that worry was also gone. Then in terms of cost, yes, there is a heavy capital investment back then at that time, but now there are better models that have come up. Even no upfront payment models are there. So the newer people who are deciding on robotic systems, you can think of this and work it out. Now, the biggest factor is this consumable cost. These are all meant to be the visa discs, the bone pins, the saw blades, the checkpoints, all are supposed to be single-use items. In the Western world, they just use it for one case, and it costs close to ₹1,00,000 if you do use and throw. But with multiple use, we have realized that our accuracy is not compromised, and that the cost can be significantly brought down to about 10 to 15,000. So to conclude, there will be several doubts while adopting robotics for arthroplasty. Once you're convinced that it will do benefit to your patient, you will still be left with major concerns. Cost is a major concern, but with multiple companies in the market and variable payment models, capital cost can be optimized, and reuse of certain consumables within careful limits, though off-label, has not caused any compromise in our experience. So time negative becomes time neutral and eventually time positive. Thank you.